My name is Liz Carson and the lecture I'm giving today is Prevention of Obstructed Labour. So the learning outcomes are to understand the use of the Partograph, to recognise slow progress in labour and manage appropriately, and to practice the skills needed to respond to a woman in obstructed labour. A Partograph is a graphical record of progress in labour, which also includes a comprehensive record of maternal and fetal vitals. It should be used by all skilled birth attendants and used in all facilities conducting deliveries. It started once a woman is in established labour, and it's absolutely essential for making timely decisions to diagnose failure to progress and prevent obstructed labour. Established labour must be correctly diagnosed before starting the Partograph. There should be regular painful contractions, at least 3 in every 10 minutes, with progressive shortening and thinning of the cervix and a cervical dilatation of 4 centimetres or more. This may vary in some countries and 5 centimetres may be used. A modified WHO Partograph is used where there is no latent phase. So as I said, it's only commenced when established labour has been diagnosed. It has 2 pre-drawn lines on it, an alert line and then an action line, which is 4 hours apart. They represent a dilatation of 1 centimetre an hour. The first plot on the Partograph should always be the cervical dilatation, which is on the alert line. So for example here, at 5 centimetres it's plotted with a cross. Then write the actual time that the vaginal examination took place in the box to the right of the line that all the other observations will be entered on. So it's at 11 o'clock here, and then plot the descent of the head, which is palpated abdominally, with a circle. Plot the fetal heart with a dot in line with the cervical dilatation, and then every half an hour. Listen for decelerations. Join the dots with a straight line and always differentiate the fetal heart from the maternal pulse by checking them both together. Findings on vaginal examination are recorded. If the membranes are intact, it's recorded as an I, or if an artificial rupture of membranes takes place, that's recorded as an ARM. If amniotic fluid is clear, it's a C, or an M for meconium, or it may be B for blood. On vaginal assessment, if the fetal skull bones are opposed, moulding is recorded as 1+. If the sutures are overlapping but reducible, 2+, and if the sutures are overlapped and not reducible, 3+. Palpate the strength, frequency and durations of contractions every half an hour. Record the number of contractions in 10 minutes by the height of the block and indicate their duration and strength. They could be contractions less than 20 seconds, 20 to 40 seconds, or more than 40 seconds. So here there are contractions 2 in 10 lasting 20 to 40 seconds, 3 in 10 minutes lasting 20 to 40 seconds. The maternal pulse rate should be checked with every fetal heart rate recorded and plotted with a dot. Maternal blood pressure and temperature is taken every 4 hours unless there's an indication to take more frequently. For example, if there was a maternal pyrexia, the blood pressure is recorded with arrows joined with a straight line. If oxytocin is being used for augmentation, record the amount of oxytocin and the volume of the fluids in which it's being administered. Record the drops per minute every half an hour, and also record any other drugs or fluids that are being given to the woman. Encourage the woman in labour to urinate regularly and measure the volume and test it and record urinalysis each time urine is being passed. Expected progress in labour is that contractions are regular and become increasingly stronger and more frequent. The cervix dilates at least 1 centimetre an hour, and there is descent of the presenting part palpated abdominally. So, how can we assess the cause of slow progress in labour? It could be the powers, and by that I mean that there's been inadequate contractions leading to a dysfunctional labour. It could be the passage, where the pelvis may be too small for a baby. There may be a degree of cephalopelvic disproportion, CPD, or it could actually be the passenger or the baby lying in an abnormal presentational position, or perhaps the baby has a fetal abnormality, a large head, such a hydrocephalus, or it could be the psyche of the mother. She might be a frightened, anxious woman. All women deserve respectful and compassionate care. We need to ensure that they feel safe and cared for, and that will include providing them with privacy and maintaining their dignity. If a woman's scared and hungry and has no companion with her that she knows and can support her, it can interfere with her contractions. Encourage women to be upright and mobile. If their contractions are spaced, that will often be enough for them to return. Ensure they're not hungry and they've had something to eat and drink, and the environment that they're in is safe and they feel cared for. Conditions for safe oxytocin augmentation. Misuse of oxytocin can cause rupture of the uterus. It should only be used in primogravid women and only after rupture of the membranes. It's important to be able to provide one-to-one midwifery care for these women. There should be no signs of fetal distress. The contraction should be less than 3 in every 10 minutes to avoid hyperstimulation, and the maternal condition must be stable with normal vital signs. Failure to progress in multiparous women is not normally due to contraction problems. So powers in labour are our uterine contractions. Slow progress in primogravidas is often due to inadequate, incoordinate and infrequent contractions occurring less than 3 in 10 minutes. So our aim is to restore normal progress by rupturing the membranes and or giving oxytocin by intravenous infusion according to our local facility regime, providing our safe usage conditions which I discussed earlier apply. We need to reassess progress in 2 hours. Progress will be slow until there are strong regular contraction pattern. If there's no further progress, then the woman should be delivered by caesarean section. Slow progress in labour could be due to the passage or the passenger. Cephalopelvic disproportion could occur because the maternal pelvis may be small. There may have been an injury to her pelvis. She may have had a disease such as rickets, which has distorted its shape. The passenger or the baby may have a malpresentational position. It could have an abnormality such as hydrocephalus. If slow progress becomes no progress and no action is taken, labour becomes obstructed. The woman will show signs of dehydration, become tachycardic, develop a raised temperature and signs of sepsis. Her urinary output will decrease and her uterus may rupture. fetal heart rate will become abnormal and the fetal heart sounds may be absent, and the intrauterine death can occur. To illustrate slow progress to no progress, here is a partograph of a woman who is a gravida 1 paranaught in spontaneous labour. Let's look first at the cervical dilatation. The partograph was correctly commenced when the woman was diagnosed in established labour. She had regular contractions, and on vaginal assessment, the cervix was 4 centimetres dilated, which was plotted correctly on the alert line, and the descent of the head, palpated abdominally, was 4/5 palpable. 4 hours later, she had a vaginal examination, and the cervix was found to be 6 centimetres dilated, with the head still 4/5 palpable per abdomen. An ARM was correctly carried out because there had been slow progress. 2 centimetres dilatation in 4 hours, when the normal dilatation rate would be 1 centimetre an hour. 2 hours later, a further vaginal examination was carried out, and the cervix was 8 centimetres, and the head remained 4/5 palpable. A further 2 hours later, a vaginal assessment found that the cervix was 8 centimetres with the head still 4/5 palpable. If we look at the contraction pattern, we can see that the woman has been contracting 5 in 10, lasting greater than 40 seconds for 2 hours. Slow progress became no progress. The woman is now in obstructed labour. The fetal heart now shows a tachycardia. So we had slow progress, we have no progress. We now have fetal distress. An ARM augmentation has already been carried out. This woman will need immediate delivery and careful monitoring until that takes place. A baby was born by caesarean section, a live male weighing 4 kilograms. Slow progress in the second stage of labour. So there is delay in descent of the presenting part and delay in expulsion. It's very important to assess this carefully using abdominal palpation to assess descent of the head and vaginal examination. If there is slow progress in the second stage of labour, it may improve if you help the woman to adopt a more upright position or to go onto all fours. You could consider augmentation in primogravid women only. If on abdominal palpation the head is 2/5 or more palpable, then the woman would need delivery by caesarean section. But if the head is deeply descended into the pelvis with less than 1/5 palpable abdominally, then delivery could be assisted using a vacuum extraction if staff are trained in this procedure. Correct use of the partograph enables careful assessment of maternal and fetal well-being and progress in labour. Intravenous fluids may need to be administered, and if there are signs of infection, antibiotics can be used as appropriate. The woman must be supported throughout with a companion of her choice, and delivery can be carried out by an appropriate method, be it caesarean section or vacuum extraction. There will be opportunities to practice the use of partographs and ask questions in our further sessions which are being arranged. The WHO partograph is a vital tool in caring safely for all women in labour. It's commenced when a woman is diagnosed in established labour. She's contracting regularly at least 3 in 10, and on vaginal assessment there is thinning and shortening of the cervix and a dilatation of 4 centimetres or greater. The first plot on the Partograph is the dilatation of the cervix on the alert line, and the time this assessment takes place is written in the box below. Assessment of problems during labour will include assessment of the powers, which is the uterine contractions, their strength and frequency. The passage, if there is cephalopelvic disproportion. The passenger, is there a malpresentation, a breach or fetal abnormality? Also very important is the woman's psyche. Is she receiving respectful care? Does she feel supported and have a companion with her? Are we encouraging her to be in an upright position, adopting all fours? Is she eating and drinking? We may feel that if the slow progress, an ARM, artificial rupture of membranes, may be appropriate with careful reassessment. Oxytocin can only be used in certain situations. The woman should be a prima gravida. The membrane should be ruptured with a normal reassuring fetal heart and normal vital signs. The woman should be contracting less than 3 in 10 to prevent overstimulation. And to achieve these safely, the woman would need one-to-one midwifery care to ensure that oxytocin does not cause hyperstimulation and could lead to uterine rupture. Obstructed labour. The Partograph allows us to recognise slow progress and when slow progress turns to no progress. This timely recognition can enable us to transfer a woman, if necessary, to an appropriate comprehensive health facility. Neglected obstructed labour has serious complications for both mothers and babies, with a high mortality and morbidity rate. For women, there can be uterine rupture, sepsis, hemorrhage, obstetric fistula. Fetal hypoxia and death can occur. Women will require delivery, which could be in second stage if you have a competent practitioner and equipment, by vacuum extraction, or if not, by caesarean section. Thank you very much.